Hi, my name's Jo Gibson, and I am an upper limb rehabilitation specialist and a consultant in private practice, working in Liverpool in the UK. Those of you know me that will know that until about 4 weeks ago, I was also working as a clinical specialist physiotherapist in the Liverpool upper limb unit. So on to new adventures, but still very much popping on here every Monday night to share some shoulder gems and talk about some interesting cases that I've seen in the clinic, but also just to reflect on some rehabilitation challenges. So I've got quite a few things lined up for the next few weeks, based on questions I've been asked on the courses, about specific tools in rehabilitation, about some challenging cases, all sorts of things to whet your appetite. But tonight I thought I'd just pop on and just share with you a patient that I was asked to review this week. Who had had what sounded like really good physiotherapy, but was really struggling to thrive. So really just to bring up a kind of condition that kind of comes in and out of trend, what gives us best value in terms of diagnosis, and importantly, where things perhaps had gone wrong with this particular chap. Now, this was a 24-year-old rugby player, recreational rugby player, not playing any particularly high level, but plays every weekend, loves it, has only got into it in the last couple of years. He reports an injury about 12 months ago. He plays as a front row prop, so obviously he's going into contact situations, and he describes an original mechanism where essentially he had the ball, he was going into contact, and he took a direct kind of force through his elbow really into his shoulder, and he felt like it subluxed. Now, it didn't come out of joint, he didn't have to stop playing, he managed to finish the game, but kind of since that particular instance, he's had some ongoing symptoms in his shoulder. Now, when you ask him what the problems that he's had, he describes deep anterior superior shoulder pain somewhere between the AC joint and the coracoid. He can't really localize it. It's very deep down in the joint. He doesn't report any ongoing feeling of instability or apprehension. He doesn't feel like he's going to get that subluxation again. He does say that when he's trying to do his weights in the gym, particularly in a kind of abduction external rotation position, if he drops into extension or he doesn't really kind of set himself before he does his weights, he can get a click if he moves too quickly from one position to another. But if he controls it and really thinks about what he's doing, he can actually make the click better. The click is uncomfortable but not horribly painful. He doesn't get any symptoms at night. The other thing he does describe is he feels that if he's trying to create power at speed, like throwing a ball, doing stuff in training, that he doesn't have the same power or the same distance that he had before. But importantly, this guy has actually had an MR scan, so a plain MR, after 6 months of actually having symptoms, not doing so well with rehabilitation, struggling to get back to play at the previous level. He could tolerate training, but again, as soon as he went into full contact, those things were causing him problems again. The MR scan was reported as normal, so he was sent back for more rehabilitation, but it's got very frustrating for both him and the physiotherapist because despite throwing everything at it that they can think of in terms of cuff work, scapular work, strength work, proprioceptive work, every tool you can think of, this guy just isn't seeing any translation either into his higher load gym work or when he goes back on the pitch into contact. So what are you thinking? Because I'm sure some of you out there already have got some ideas, probably some of the key clues. Hi guys that are joining us. Lovely to see some of our regulars here tonight. But I'm sure already I've given you some clues in terms of where his pain is, how his problems started, and the sorts of things that are causing him problems. So I'm sure that you've got some suspicions already. Now, for me, as soon as I have somebody that's had some sort of either traction, compression, or direct blow to the shoulder, particularly in rugby, one of the things that I have to put in my kind of diagnostic toolbox, if you like, something to rule in or rule out, has to be a slap lesion. So a superior labral tear, anterior and posterior. Yes, Claire, you got there. You just about beat me. Fantastic. So what are the things that we need to think about in terms of slap tears? Well, absolutely, there's no doubt that trauma can be relevant. And if we look at the typical reported mechanisms, any forceful traction on the long head of biceps, a fall onto an outstretched hand probably accounts for up to 50% of traumatic injuries. Bracing in a motor vehicle accident, so people holding the steering wheel, knowing that there's about to be an impact. So that big concentric, eccentric load seems to result in slap lesions. It's recognised in medical legal literature now. Direct blows to the shoulder, so either through the elbow, indirect, or direct actually to the shoulder itself. But clearly that's our traumatic group. Now, another group that I've seen who have presented with symptomatic slap lesions, and we'll talk about when we can be confident that perhaps that's causing the symptoms, are patients who in the gym, heavy load in abduction, external rotation, little bit too heavy, lose control and get forced into extension rather than that hyper external rotation position, which is more likely to potentially take off that anterior inferior labrum. So that extension mechanism also seems to have some credibility in creating a slap lesion. Now, again, what's really interesting, I think particularly in something like rugby, high adrenaline sports where lots going on, generally we say with any trauma, if it's relevant, then it causes symptoms and that player has to stop immediately. But as I say, rugby players, it seem a specific group that often they continue, and yet then when they, after the match and when they start get back to their training, these things show up. Now, interestingly, Ian Horsley's done some lovely work looking specifically at the rugby cohort, looking at patients who had ongoing pain and instability despite physiotherapy, and found that in over 50% of them that related to direct tackling, then followed by a fall on the arm. But there were 30% of cases that couldn't actually recall a definitive injury, even though they found clear evidence of labral pathology when they scanned their shoulder. Now, of course, what we have to be clear about is when this is relevant, because if we look at the different causes of slap lesions, we clearly have the traumatic sporting group, which is probably the easiest group, both in terms of diagnosis and identifying a management plan if they haven't done well with rehab. But clearly we have the overuse, we have the throwers, where again slap lesions can just be a feature of the fact that you've thrown a long time. It's a question of, does that then become a cause of symptoms, or is it just an anomaly and a normal finding as a response to load? And then we have the group that are probably massively overtreated, an over 40 cohort, where we see slap type 1s that are probably just a degenerative phenomenon, just some fraying in that superior labrum. Now, if you look at classification systems for slaps, I'm not going to go through them all tonight. There's so many different ones. There's about 10 different descriptions of slap tears. Burkhart's was the original one, which was just a nice simple 4, but it's expanded to include all sorts of things with the work of people like Moffat. As clinicians, what matters to us is whether or not that long head of biceps attachment is stable or not. So if you imagine, well, there's a big issues with slap tears and why they're so inconsistent and difficult to make sense of the evidence, is that there is a big variation in attachment of the long head of biceps into the superior labrum. Some it's more anterior, some it's more posterior, some it is generally all the way across the superior labrum, some have a more mobile attachment, some have a more fixed attachment. So you can see that depending on the same mechanism of trauma, it can potentially have a very different effect in different athletes. Now, as I say, from our point of view, those degenerative frayed tears really are probably just a consequence of loading or perhaps of ongoing cuff pathology, but generally don't need anything doing. But in somebody like this guy who's had clear trauma, who gives a clear picture that when he winds that shoulder up, so potentially he's lost the stability of that long head of biceps, he has symptoms, a consistent pattern of loading that reproduces his symptoms. Similarly, he describes that loss of power in those provoking positions, which again are very consistent with slap lesions, both in an overuse population and in a traumatic group. Now, as I said, instability often isn't a feature in these patients. If they do get any feelings of subluxation or a little bit of instability or lack confidence in the shoulder, interesting, it's often more in low extension positions rather than those wind up abduction, external rotation extension positions. So these lower positions, and if you think of a circle concept, that superior labral tear just gives a bit of pseudo laxity lower down in the joint. So some interesting things. Now, the issue with diagnosis, no great surprise, as with all things in the shoulder, it isn't without its challenges, primarily because certainly in those overuse or those degenerative groups, they're often seen in association with other pathology. But even in that lovely work by Ian Horsley, they also found that about 75% of rugby players with slap lesions had associated changes in the curve, potentially the AC joint. So you can imagine that diagnosis can be a real challenge. And this is why knowing where the pain is, what makes it worse, what potentially relieves it, certainly some of those questions about strength in positions where we need that kind of security, if you like, of that superior labrum, that helps us weigh up the story one way or another. So remember, we said that the two most common descriptions of pain relating to SLAP lesions are either deep anteriorly, so often they'll kind of point between the acromion and the coracoid, so deep in the joint somewhere, or they'll do the same posteriorly, so it can be posteriorly in the joint. So they can't touch it, but it feels like it's deep in there somewhere. Now, in terms of mechanical symptoms, again, people get very excited about clicks and pops and cracks, but you'll be interested to know that actually up to 50% of patients with SLAP lesions that go on to have surgery because of specific symptoms don't actually have any mechanical symptoms. If they do, in combination with some of our special tests, then it can weigh up the kind of bias, if you like, of being more confident in making that diagnosis. But we don't need them. And equally, if we have it, you kind of want symptoms or pain associated with that rather than a painless click. If you joined us when we talked about clicks and people feeling out of place, then those can just be a normal anomaly. There do seem to be some risk factors associated with an increased risk of getting SLAP lesions, particularly in throwing populations, and no great surprise, that's increasing stiffness in the back of the joint, which we know relates to cuff fatigue, but also kinetic chain injuries. So some lovely work by Aaron Siaska that says if you have those things, and particularly if you're a pitcher, you're more likely to end up with a SLAP lesion that will need something doing. But in contact sports, really, other than the fact you're playing contact sport, and if you're in that front row, you're even more likely, the bottom line is the sport itself is probably the biggest risk factor. Now, as I said, in terms of symptoms, we've talked about instability is uncommon, and if it is, it's in those lower positions. We've talked about mechanical symptoms in terms of clicking and popping. The other issue is that often there is a delay in diagnosis of making these things. So actually, often what patients will present with is AC joint tenderness and biceps tenderness. But when you actually hear the story back, they say how it started with deep joint pain, because again, just the subtle compensations and the fact that the attachment of that long head of biceps is no longer stable potentially means that that biceps gets a little bit tendinopathic because it's under a different loading pattern, and it can get a little bit unhappy in the groove. So as ever, you can imagine our detective work going back to that subjective history, fully understanding the original mechanism and then how that actually manifested in terms of symptoms and how it's affecting them in loading activities are absolutely pivotal in making that diagnosis. Now, in terms of clinical tests, there'll be no great surprise to know that special tests in SLAP tears are probably the least special. Currently, there is still a massive agreement that arthroscopy remains the gold standard for being able to identify these lesions. But just hold that for a moment, because we'll come back to the fact this guy had a scan. If we look at clinical testing at the moment, it is fraught, and there is absolutely no doubt there is no one clinical test that can rule out a SLAP lesion in terms of our special tests. Now, O'Brien's active compression test, where we take the arm into cross adduction about 15 degrees with the arm fully pronated and ask them not to let me push them down. If that produces pain that's deep in there somewhere, we repeat the test with supination and the pain's less. That's meant to be a positive test. Now, when O'Brien published this, it was all very exciting, 100% reliable, but they only actually scoped patients with a positive test. So no great surprise when other authors tried to reproduce the same results, they didn't have anything like the same success rate. So are there any tests that give us good value? Well, I've been really lucky to be involved in writing a chapter, well, 2 chapters on instability with some fantastic co-authors for the recent shoulder textbook. And obviously we had to do a comprehensive look at the literature was out there. Now, interestingly, a meta-analysis of pooled diagnostic accuracy values recommended with caution, and that's massively underlined with caution, the anterior slide test, which is when the patient has their hand on their hip, you stand behind them, fix their shoulder, and then essentially put a compression loading through the humerus into that kind of anterior superior labrum, and pain and or a click is meant to be a positive test. Now, on its own, combined with mechanical symptoms, there is some tenuous that can help rule in with the right subjective history. However, if we combine the anterior slide with Jurgensen's, which I'm sure you'll remember is your resisted supination with the elbow flexed by the side, so generally a biceps test, but does it reproduce the pain that's deep in the joint somewhere? the compression rotation, which is lying the patient down and basically doing a McMurray's, where you add load through the humerus into the glenohumeral joint and then rotate like the McMurray's test in the knee. Again, do you get pain and any mechanical symptoms? So that was one meta-analysis. Now, the other study that looked at combinations of tests and compared it with MR arthrogram, interestingly, suggested that a combination of biceps load 1, biceps load 2, speeds, passive compression, and O'Brien's, if 3 or more of those were positive, then actually you didn't need to do an MR scan. Now, a very quick review for those of you who don't remember those different tests. The biceps load 1 is basically just an extension of your apprehension test and actually was designed for patients who'd had a dislocation, but that anterior inferior labral tear might have extended into the superior labrum. So essentially you took them into a 90-90 position, they feel apprehensive. If you add resisted elbow flexion, does that apprehension go away? If it does, it suggests that the long head of biceps attachment is intact. Now, again, on its own, pretty useless. In combination with other things, if it reproduces, if that apprehension doesn't change and one of the other tests is positive, then we just start weighing up the scales that it might fit with my clinical hypothesis. Biceps load 2 is the same kind of thing, but then pain is what we're looking for. So in 120 degrees of abduction, again, full external rotation, and doing these tests in lying makes them far more reproducible and reliable. Again, maximum range, resisted elbow flexion. Does it reproduce pain deep in the joint or make pain that's already there in the wind-up position worse? Speeds is just our typical flexion biceps test. And passive compression is one where you lie them on their side, fix the AC joint, and then again shove the humerus, if you like, up into the superior labrum and just move it round by actually extending the arm. So there's a very common theme to these tests. Now, what I would say to you is, if the lovely work by Laurie Mitchener, and I'm going to post you a link on the Facebook page to the National Athletic Trainers Association position statement on SLAPs, because it gives you a lovely summary of a lot of the things that I've shared with you tonight. But what's very clear about Laurie's work, and Laurie's a really prolific shoulder researcher in the US, is that generally what we want is something that gives us torsional load, so that could be our speeds or something resisted, something compressive, so that could be our passive compression, our compression rotation, arguably our O'Brien's test, and then something that really winds up that long head of biceps attachment. If we take a testing approach that, if you like, considers those different ways of stressing that long head of biceps, then we have more chance of ruling things in. But the massive limitation is all those things are dependent on an unstable long head of biceps attachment. So essentially our type 2 lesions and some of our type 4. In things like bucket handle tears, actually our testing is much less consistent. So we do have to be real honest that as ever, that subjective history is key. It's 80% of our decision making. So these clinical tests are only ever a tiny, tiny part. Now, what about this guy's MR scan? Because remember, I said that he'd had a plain MR. Plain MR is notorious for false negatives in patients with SLAP pathology, and an MR arthrogram is far more reliable. It's still not the gold standard, remember arthroscopy is, but there's some simple things we can do with MR arthrogram in terms of the testing in the ABA position, so we wind up that long head of biceps attachment. We're more likely to get leakage of contrast, so more likely to get a true positive rather than the false negative. Similarly, if you add traction in certain positions, again, that's been shown to be more reliable. But remember, gives us a better chance of ruling it in, but doesn't 100% rule it out. So this guy actually did have an MR arthrogram. He had it done by an experienced upper limb radiologist. They did it in the ABA position and with some traction, and sure enough, they showed that he had an unstable long head of biceps attachment and a SLAP type 2. Now, in terms of what the options are for this guy, having failed really good 12 months of rehab, again, there's a little bit of a change in trend at the moment. Certainly, the number of surgeons that are repairing superior labral tears is gone down slightly, and what they're doing instead is a biceps tenodesis. Now, part of the issue with this is often if the long head of biceps is very, very irritable, and particularly if they've had symptoms for a long period of time, when you try and repair that type 2 SLAP lesion and retension that long head of biceps, that in itself can cause some problems. So you now have a super stable superior labrum, but now you've got a very unhappy biceps. But of course, this has got to be weighed up according to the age of the patient and what they're going back to. there's no doubt that if you look at something like Major League Baseball, and baseball's increasing in popularity in the UK, that actually patients who have Major League Baseball pitchers who have a tenodesis, only 17% of them get back to their previous level of throwing. So for them, that long head of biceps contribution to stability and strength really seems to matter. And certainly in younger rugby players who present earlier, more acutely, so potentially with less creep or change in that long head of biceps, again, a lot of surgeons would try and do a primary repair. So age, how long they've had it, the state of the long head of biceps, particularly that intra-articular portion, will all influence decision making. So what can we learn from this guy? Well, I think as ever that trauma and searching out that mechanism can be really important. Remember, most of the evidence about labral pathology is about anterior instability, and we can be confident in somebody who's under 25, dislocates, has to have it put back in, continues to have apprehension. They're highly likely to have a Bankart lesion. But remember, particularly in our contact athlete population, actually they don't need a frank dislocation to get labral pathology. Where do they get their pain? What positions do they perhaps feel they're lacking power or weakness? Do they get any crepitus? Yes or no? Not essential, but it adds to the story. And importantly, how does it behave? So you can see how, again, we build that story in terms of our clinical reasoning, but don't be deceived in patients who might have had a history that's 1 year or longer, because remember, we also know the sequelae of traumatic slap lesions is they develop some AC joint stiffness and they get an unhappy rotator cuff. So it's all about going back to the very beginning, peeling away the layers of that onion and trying to make sense of what they say. So I think this is a really good example of how plain NMR is not infallible when we look at labral pathology. As I say, in somebody like this, an arthroscopy is really the gold standard, how our history really matters, and that this is an example that structure does matter sometimes. So guys, I hope that was interesting and shared with you some interesting things. Let me just have a wee looky. We've got some questions. Hello. Claire got that right. So Tim says, Tim's always here with great questions. Tim says, should biceps tenodesis be considered in slap lesions when traumatic instances aren't apparent? Yes, absolutely. And I think the important thing, Tim, is putting it together with that feeling of weakness or those feelings of instability in low extension positions or those loss of power. And of course, somebody with tendonitis is an interesting one. We could have a whole argument about when it's tendonitis and when it's tendinopathy. Let's just call it tendinopathy to make life easier. But there's absolutely no doubt that patients who have an unstable type 2 slap lesion, where basically we've got, every time we tug on biceps, it pulls on that superior labrum because it's lost its normal stability, the biceps can get very unhappy. And as we know from the evidence, biceps tendinopathy is generally secondary, not primary. Only about 5% of all biceps tendinopathy is primary. And actually people who might have moved house over the weekend or suddenly done a load of biceps curls, but otherwise it's quite rare. It's usually the victim, not the culprit. So there's absolutely no doubt that slap lesions would have to be part of my differential diagnosis. And if we look at the groups that might be relevant, then young, overhead, manual workers, as I say, throwers, absolutely for sure. But again, it's fitting with that subjective picture of a gradual loss of power, an inability to create strength, perhaps some mechanical symptoms. But again, all the things I've talked about that would help you weigh up whether it's just the cuff that's got a bit tired and that's why my biceps is unhappy, or whether there is actually something structural that's precipitating that. So I hope that answers your question. Oh, guys, as ever, I'm not very good at sticking to 15 minutes, am I? So lots to pack in there tonight. I know there's loads of other different slap tears out there. I've just shared with you the best of what we've currently got in terms of the evidence, good methodological research. Now, I'm very aware that clustering is not without its flaws and is potentially questionable. So the key thing about this was really plain MR is insufficient when we're querying labral pathology. There may be ways of making our MR arthrogram even more reliable in terms of positioning. So having a radiologist who is au fait with the recent evidence that shows how to make it more reliable is very, very useful. Remember, mechanism of onset is everything. Don't be deceived in patients who have long-term symptoms, but as ever, it's about putting that whole picture together. So guys, I hope you've enjoyed it. As ever, try to give you some useful clinical tips and tricks to take away. Next week, we're going to look at something I've been asked as a potential rehab tool, and do I think it's got a role? I'll post you the link to that National Athletics Trainers Position Statement, because it's got a really lovely summary of a lot of the stuff that's out there. But guys, otherwise, thank you so much for joining me on this Monday night. I'm trying to read anything. Oh, Amy, that's lovely. So some very nice words from lots of people. Thank you so much. Guys, I hope you've enjoyed it. As ever, I'll be back here next Monday for some more shoulder geeking. As ever, David will no doubt put this out as a podcast. It will still be available on the Clinical Edge website, and I'll post you some useful links. For now, I promise I'm going to leave you to the rest of your Monday evening and look forward to you joining me for another one of these very, very soon. Bye for now.